You're listening to The Dental Guys, episode 43. Let's put some rubber in that dam. The next step in The Dental Guys' Guide to Endodontic Therapy. In this episode, we're almost ready to get a file in that tooth. But before we get to that, we have to cover anesthesia, isolation, and access. And even a bit before that, by popular demand, we opened this can of worms. Do you need a microscope to do quality endodontics? And how do scopes compare to loupes or cone beam CT for endodontic diagnosis and, more importantly, for treatment outcomes? We're almost ready to break out the bleach this week on The Dental Guys.
Welcome to this week's show of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy.
John, it's summertime, and, you know, it's starting to get warm. Oh, man. It's so nice outside right now.
It's awesome.
I mean, and really the weather's setting it up perfect for a really good summer. I know we just had some good rain, and it seems like we're in this continual cycle of rain and then sun, which is great for you know, being outside,
getting out and doing stuff,
and
everything's
hiking.
Pretty. The rivers are going, and fish are biting,
so fun. You know, but practice is kicking up too. I mean, because some people, you know, change their schedule up during the summertime. They might alter their schedule a little bit. I know you and I just pretty much keep it rolling, just like we normally do. You know, our normal Monday through Thursday, and an occasional Friday if we need to blend one in here and there. But something is happening in your practice.
Oh, yeah.
Oh, my word, dude. You told me today, and I'm like, you're really doing this, man? I mean, like, really? What are you doing?
It's one of those scary things that, you know, some people face where, you know, you think about what are some things that are scary to everybody in your practice, and one of those is changing software, and that's what we're doing.
What?
Yeah, this Friday, we are shutting down the office. I mean, we're shut down anyway, but yeah, it's a real shutdown. Like we're switching from.
It's like a nuclear power switch button or something.
Oh, it
like
is, man. It's like and you hope it doesn't go like critical on you, you know. But we have for years and years and years, much long before I became involved with the practice, we used SoftDent, which has been, it's one of the, I think it's the oldest. Like, it was all DOS based, you know, way back in like the 80s. I think it was one of the first practice management softwares. Yeah.
Some of our some of our people out there, disk operating system from Microscope.
MS-DOS.
MS-DOS.
Did you say Microscope?
Microscope.
We scoff at you.
We scoff at you.
So this Friday, we're going from the old school of SoftDent, one of the original ones, to one of the newer ones, which is Open Dental. And I've heard nothing but good things about Open Dental for years.
Hey, they're not a sponsor.
Yeah, maybe we shouldn't talk about them. Like, maybe we should let them tell us why they're so good. But you know, I've been hearing nothing but good about them for so long. And one of the things that we were needing is just, you know, we've seen this incredible slowdown of our system over the last few years, and it's not a hardware problem, it's a software problem, because, you know, SoftDent's back-end server stuff just doesn't work very well anymore. Yeah. And they don't want to change it because it would mean, you know, a huge investment, and some people don't want the change. So
let me ask you this, you know, this would be a good show to talk about, like, the softwares that are available out there, and really what the whole, you know, I think you know enough now after diving into this. How long have you been preparing for this?
Man, about 2 years. 2 years.
Well, whoa, wait a minute. You said 2 years.
Yeah,
okay,
it's kind of embarrassing.
What is kind of went into this preparation? I know you research stuff like I do, but
yeah, that's part of the problem is research, because, you know, this is one of the things about this show, Wes. I mean, you know, one of the biggest things we got into the show because of is that there's no good way often to find out about what is really good until you actually use it. There's not an independent research place out there for software. So it took me a while to track down people that were using the software that had switched from Soften or from other I needed to know when I switch, am I going to keep all my data, or is a bunch of it going to just go away? How high fidelity is the transfer over of all the information? Also, you have to decide, is it going to work better compared to cloud-based software, which is the newest stuff? So I had to track people down that were using cloud-based software and talk to my IT company. It's a dental-based IT company, and ask them what was working well for support and what companies they felt were the best to work with. And then I talked to people that had gone, again, complete the other way toward the cloud, and said, well, then you don't have to spend so much money on your hardware. So I just basically said, I've talked to enough people that I felt like it was time. And I feel now like after
you didn't
I've
talk to me.
Well, I know what you're all about. You want a lot of the same things I do. You want to have a software that is going to be pretty agile, but you're also looking for something that's stable. And I think it's hard to find a middle ground between a stability of like the old school, not old school, but some of the more established software, and the maybe cutting edge, which you don't always want cutting edge when it comes to your dental practice management software, because you can't be down. It's not okay to be down. So anyway, that's another show, like you say, for another day. But it's been a lot of just, getting all the stuff lined up. Plus, you have to train. Like, oh my goodness, man, to train your staff, it takes months, I think, to get to the point where they're comfortable.
Yeah, so this is going to be a big deal. I'm excited to hear about your transition. Because
hopefully it'll go smooth. But we're bringing in a trainer. We're flying in a trainer for the day because we're trying to do it right, and it's not cheap. It's going to cost us like $3,000 for this day of intense training.
Yeah, but that's probably your biggest expense in all this, I would say.
Oh yeah, because the software, Open Dental, is very cheap, and it's very cheap overall, and that's one of the advantages of it too. But yeah, that's our biggest expense, is the training, and hopefully it'll pay off. I think it will. I definitely know it's going to be an upgrade from Soften. So I'll let you know probably in about a month or two after we get some of this stuff ironed out. I mean, I just want to be gone on Monday. I just want to get sick so I don't have to be there. So hopefully we're still talking next week and I'm not going crazy.
Well, last week we talked about diagnosis in endodontic worlds, root canals, and I know you all have been waiting, and we're a little delayed on the release because some of us have to go on vacation, but actually the main reason is because we're Comcastic, and sometimes Comcastic is not so Comcastic, and we had an internet outage at John's house a few weeks ago. And as you know, we try to record ahead, but we're up against the deadline, as they call it. And our editing crew will have to burn the midnight oil. So if this is a little delayed, don't worry.
Yeah, it's worth it. It's going to be worth it.
So we have been geeking out for you guys. And today is the day where we go from diagnosis into treatment. We've determined from the last episode how to diagnose whether a person needs a root canal or an extraction, whether it's a treatment that needs to be done. But today is the day when we actually start treatment. Yeah. And we're going to equip you guys with the tools that you need and some knowledge about what you need to start incorporating into your practice. I think that's the thing here, is that there are so much things you could just get involved in and buy, and it's mind-boggling how many systems, endodontic systems, there are out there. But what really matters? Right. And I think the first thing, John, is some questioning that happened since the last episode released. We had some private messages going with some really highly educated people about endodontic diagnosis, but then more importantly, what do we need for this endodontic treatment? And John, start us out with topic one.
Oh man. Well, I have to first just forewarn you, for those of you that don't listen to this show, that we're about to enter Geek's Corner.
Geek's Corner. Geek
I'm excited about that.
Hey, listen, Obi-Wan Kenobi.
In fact, if you're watching the show, on YouTube. I just want you to notice that
John has a
I am
Nova
wearing
shirt on.
a Nova shirt, as in Nova from PBS, like where it was
Cheers.
like the intro was like, you know, dude. If you remember Nova, you got to give a little shout out. But anyway,
listen, I love Nova.
I know it's so good. We're gonna geek out for a minute because
Geeks.
After we,
this is why you listen to us.
Yeah, exactly. If you're still listening, we know you're really on board. So when we started, when we put the show up, the last show up, and one of the things we talked a lot about was CBCT. Anybody listen to that show? If you haven't, I would recommend you go back to episode 42.
Stop right now.
Yep.
Stop
go back.
Go back
because
to 42.
It's not going to make sense as much if you don't listen to 42. But after you listen to 42, so we talked about the correlation between CBCT and histologic findings, looking at lesion detection. You know, how often do you see periapical lesions on CBCT versus periapical radiography? We pretty much tried to establish just essentially what the AAE, the American Association of Endodontists, has said, which is that CBCT is the imaging modality of choice for molar root canals, as well as several other areas that they recommended. We went through that in episode 42. And I think from that, what a lot of people got was that we were advocating CBCT as being like the essential tool for endo. And the question that a lot of people posed to us was, well, what about microscopes? And I say that kind of tongue in cheek because I'm not just giving you guys a hard time, because you're some really, really smart people out there who are very good operators with microscopes, who we respect a lot, who ask those very, very reasonable questions. And we really got into it more private messaging because we didn't want to we were waiting for the show. We knew the show was coming, and we knew some of these things would probably get brought up.
It's so hard to like not release shows.
I know.
Whenever we respond to these questions, because we want to save it for the show.
Yeah, we don't want to put it all on Facebook, you know, or something, because it's so hard to digest text compared to listening and really thinking through it. We want to make sure we're thinking through it and we're truly doing the research, not just spouting off something that we heard from somebody. So the big question that we were faced with, and we had already done some research on this, but not as in depth as we did.
Hey, let me just say this. Some of you guys out there, we respond very quickly to. Some of you will get a question and we'll look at it and you'll see that we've seen it. Or you'll wonder, like, are they really looking at me? Because we have a really good response rate.
Yeah.
But sometimes we don't respond for a while. And the reason why is because John and I'm either waiting for John or John's either waiting for me.
Yep.
And then if we don't both respond, he and I are talking on the phone and we're saying, how are we going to respond to this? Because John and I like a unified front from a standpoint of like, if we're the dental guys, okay?
Right.
Because we're getting ready to answer something here that I feel like that is going to be something that a lot of people are going to listen to, but we as the dental guys want to have a unified front. We might disagree to get there, but we're always going to be unified. And if we ever change that unified front, we'll let you know.
Right.
Okay?
It was kind of like what happened with the CBCT change. We went through that in the last show where, you know, Wes basically said, hey man, I'm taking CBCT on all these cases. You should be too. And I was like, well, why? Like, show me the evidence. And Wes dropped the evidence on me and said, here it is. And I'm like, okay, cool. Like, I would have argued with you before that, but now I get it. So that's the same way we want to treat these types of questions. So when someone says, basically, should we have a microscope first? Should we have a CBCT first? Which is the most valuable? Which is going to be the thing that makes your endodontic procedure, number one, the easiest, number two, the best? And there's a lot of facets to this. And so we just started diving in by asking the question of, well, let's try to find a way in the literature to actually assess that. And basically what I did to start is with some of this is I said, well, let's choose, and Wes, you know, and I talked about this and we said, let's try to choose a measurement in the literature that gives us the best idea. And there are two things we wanted to look at. One is how easy is it to find canals and, you know, to get to where you want to get to, where you can see better. Obviously, the big thing with the microscope is seeing better. That's the whole sales part of a microscope with endo, is seeing better. But the second part of that is, well, does it actually give you better outcomes? So that we wanted to look at both of those things, and we started looking through the literature and we found some great studies on that. So the first thing we went through is, Wes, the the percentage of MB2, that was one of our things we started with, was finding MB2, because it's one of those things that commonly people struggle with. It's a good measure, I think, of how well we can see things, is can we identify MB2? What is the overall percentage, according to the literature, of MB2 in maxillary molars?
So do you need a CBCT versus a microscope, or do you need both? That's the question we're going to answer here.
Yeah.
And we know that 57% of the time, histologically, that mesial buccal canal of maxillary first molars, number 2, the mesial buccal 2, is there 57% of the time. So, you know,
so 57% is what we're shooting for. Okay, so that's basically saying that if you're really good, that you should be able to be finding MB2 in 57%. Now, why does this matter? Why are we picking MB2 to measure this microscope CBCT thing? Well, it turns out that's been a lot of the way the literature has evaluated the effectiveness of microscopes versus no microscope, is looking for MB2. And that's a reasonable measure, because that's one of the hard canals to find. So in theory, if the scope is good, if the scope is better, then we should be able to find MB2 more commonly than we do. And what about, could we possibly find a study or some studies that compares CBCT with a scope in finding MB2s? And wouldn't it be even better if the study also included ultrasonics in helping to find MB2? Well, it just turns out that there is a very, very nice study that we're going to link to in the show notes, which is titled Efficacy of Clinical and Radiologic Methods to Identify Second Mesiobuccal Canals in Maxillary First Molars. That's a pretty broad topic, a pretty heady topic. And what it basically did is it did exactly what I just said. It studied a series of teeth, and they went through a pretty cool, and I don't want to read the whole study to you, but I just want to try to summarize it as succinctly as I can. What they did is, first they took periapicals of maxillary molars, and they saw how many MB2s they could find. Then they did an access and an examination to see how many MB2s they could find. Then they did a CBCT to see how many MB2s they could find. Then they did an operating microscope to see how many CBCTs they could find. And then they did ultrasonic inserts, if they didn't already find the MB2, to see how many MB2s they could find. And it was a really cool study because it truly compares between every modality that we have available to us right now to determine what's the best way to find MB2 canals, because it's a good measure, I think, of how effective scopes are. So what was the result? Well, you can read it for yourself. I'd recommend you do. But what they found was that periapicals, not surprisingly, were the worst. They only found it in 8% of teeth. 8% of teeth, they found the MB2. When they opened the tooth up and did their just clinical exam, okay, with no scope, no CBCT, 50% of the time they found MB2. That's pretty good. That means that you're getting up to close to already the number of 57% without anything. Mm-hmm. But interestingly, CBCT found 54% of the MB2s, which is pretty darn close to 57, and an operating microscope was 54% also.
Whoa. Stop just a second there. What you're saying right now is that the incidence of finding MB2 with a CBCT, a cone beam machine, is equal to that of using a scope.
Yeah.
And it's real close to that of not using anything, no scope.
Right. 50% you found with no scope at all. And then when you added the ultrasonics, they were able to get it up to 62%. That was their highest number that they found with ultrasonics.
But that was not clinically significant.
Right. It wasn't a significant difference, but they found that they were, roughly the thing that was interesting here, that was interesting to us the most, I think, was that they found the same percentage of MB2s using CBCTs they found with the scope. Yeah. And that, I think this study is pretty bulletproof from the standpoint of...
It's a really good study, and we'll put the link in the show notes below, and you can check that out on our website. And if you really want a copy of these, we'll throw them up on our Dropbox and send you a link to these, because these are free. So
yeah. So their conclusion was, and again, read it to make sure that you get the same conclusions. But I'm just reading right from the results here, that they found that there was no significant difference in detection of MB2 between CBCT and a scope. And the only significant difference was between periapical radiography and all other modalities. So what this said to us was that it really was about equal. It was about equal. So we said, well, okay, hold on though.
Hold on a minute. Yeah.
Right. Because one thing that we need to make sure is, well, let's see about, does literature have any other articles that
full disclosure, John and I are not specialists. Okay.
Right. Oh, yeah.
Number two, both of us do not have microscopes.
Yeah.
Number three, we do have a CBCT machine in our office. Okay. And number four, we use loupes.
Right.
John, I was using 3 5s.
Mm-hmm.
And before that, about 10 years ago, I was using 2 5s, 1.7 magnification equivalents. And now I have 6 O's. And John, what's your loupe of choice right now?
Yeah, I'm using a 4.5.
A 4.5.
Yep. So we both rely on our loupes pretty heavily.
Right.
And so the next question I guess we had after this was, okay, if CBCT and the scope appear to be equal in detection of difficult canals like MB2, what's the difference between a scope and loupes? Okay, because a lot of times you'll hear people say things like, oh, well, you got loupes, but you really can't see anything until you have a scope. Now, we agree with the fact that you can see more with a scope. The question was, is it statistically significant? Is there actual literature to back up that with endo, that you see more difficult canals? And again, the AAE in their Winter 2016 Colleagues for Excellence, they talk about this, and
this is a specialist organization, guys.
Right.
These are people that want you to refer your cases, or if you're an endodontist listening to this, you're listening to your specialist organization and cite multiple studies here.
Right.
That's the thing here.
We looked at this as kind of just like Wes said, this is the standard basically. If you look at where this is coming from, and they, if you just read through this, they see that that the study that compared the operating microscope with dental loupes. Okay, so 312 maxillary first and second molars. They found the MB2 in 57% of the cases when using the scope, and 55 with loupes versus 18% without
John,
anything.
I'm a new dental student, and I just finished my preclinicals. I haven't done a root canal yet on a person, and I also am poor. And I haven't invested in loupes yet, which we know is pretty rare now. But I'm in my dental school days, pretty much, I'd say half the class may had and half the class didn't have loupes.
Mm-hmm.
Okay? Are the people without loupes at a disadvantage? That's what you're getting ready to answer when you compare them to a microscope or those with dental loupes. Because 57% of the time with a microscope, we're detecting the MB2. 55% of the time with dental loupes.
Right.
Okay. What about without loupes, John? Do I need to make that investment in loupes?
Yeah, and that's pretty clear. 18% of the MB2s were found with unaided vision. So that's pretty poor. So you got to have loupes. It's absolutely essential to being able to identify difficult canals. But if you compare loupes to the scope here, we saw a 2% difference. Now, they also cite a couple of other studies that compared the scope to unaided vision, which that's not a very fair comparison, but they did say that the incidence of locating MB2s went up significantly. That's not surprising. Microscope use increased the number of root canal orifices located in mandibular molars, but that was all compared to unaided vision. What we were very interested in was comparing it from loupes, because most people are using loupes. Comparing loupes to the scope, there was a bit of a difference, but it was certainly not a significant difference. But, okay, so the next thing people say is they say, all right, well, I hear all what you're saying, but it's not just about identifying canals. Right. All right, that's great that you can identify canals with your loupes. That's wonderful. But with the scope, I can see better, I can disinfect better, I can obturate better, I can do my access better. All those things contribute to a better outcome for the patient. You hear this. That's a part of our Facebook private
Basically,
message.
they're going to heal faster. our surgical outcome here, our procedural outcome is going to be better, right, John?
Yeah, and
right?
that's what you hear.
I mean, that's what people say. They want you to think that if you have a scope, that your outcome is going to be better. But does the literature support this? And how have we ever really studied this?
Right, and that was what I started diving more into a little bit. And this
2016.
This same Colleagues for Excellence publication goes into that. Non-surgical treatment outcomes. They say 2 Cochrane reviews were done, 2009 and 2015, to identify randomized control.
What's a Cochrane review for people who haven't listened to our show?
Good
maybe
question,
you're new to our show. What's a Cochrane review, John?
So that's a great question. So the Cochrane Foundation is basically a foundation that supports trying to get kind of the definitive current understanding of research in a given area. So they will commission some really good researchers to basically do a meta-analysis or search for the highest level of evidence, which is randomized controlled trials, randomized controlled trials, to identify the true answers to some of these questions, or to determine what the state of the research is too. Sometimes they'll study it and say, well, we don't really have any good research, because the question is are there even studies out there that are reasonably done? And so their conclusion from Cochrane Review 2 separate times was that they could not identify a single study reporting on the outcome that matched the criteria put forward. Now, Cochrane reviews are very strict. They don't allow a lot of stuff in. So we have to say that, okay, that's probably true. That
it has to be really a good study, John. That's what you're saying.
It can't just be It can't just be a very simple clinical report or something, or a retrospective study. It has to actually be randomized, like comparing using the scope to not over time, randomized. Now that's hard to do. To be fair, it's hard to randomize and control that study, and so now the thing. Okay, we get all that. From that, they said there's no study, but then AAE does something interesting in this. And this is where I think Wes and I were very surprised.
I'm letting you run with this, John. Keep running.
And very disappointed in what the AAE did. And we'll talk about why we think they did it. But they go on to say, recently, however, a study published assessed the impact of the operating microscope on the outcome of non-surgical treatments of 184 teeth. And after a follow-up period of 6 months and 18 months, there were significant differences between, listen to this, between microscope and control groups, with 95% versus 88% at 6 months and 96% versus 92% at 18 months. So they say, let's go back to that. There were significant differences between microscope and control groups. Now, the AAE is basically hanging all of their reasoning for there being better outcomes on this one study. They're saying, okay, so the Cochrane reviews said there was nothing good. The Cochrane reviews said there was no studies. But this study is what we're going to say proves that. Well, it's kind of like you sometimes hear politicians say, well, they didn't read the bill. Well, most people, I guess, don't actually read the freaking study, because... So
here's the thing is, like, you guys, you have to read this stuff, because in the same instances we're following through here, and John is giving you, we're using the article to support our decision here, but we're also going to use the article to kind of shoot them down a little bit.
Yeah.
Okay? I just want to make that clear, is that because what we're getting ready to do is we're going to tell you why that what they're citing here is not good evidence.
Yeah.
Go ahead, John. Go ahead. I just want to make that clear.
No, that's good. That's good.
Because people all the time, they go on these rants on these forums, and they spout off little bits and pieces, and they pull things out of context to make what they're doing in their practice feel just a little bit better.
Right.
And I'm not saying they're wrong, but what I'm saying is that if you truly try to support what you're doing with good clinical back evidence, like a Cochrane review tries to do, trusted evidence giving you better health, then that's what we're trying to do here for you guys, to help you make good decisions on what to buy, what to use for your patient, so the patient has a better result. So, John, go on. I'm sorry to digress.
No,
but
that's
I think
good.
It's important
to point that out. It's good to point that out, because it's not just about, getting into the details matter here, I guess is what we're saying, is the little things matter in your practice. So again, getting back to what they said is they said there were significant differences between the microscope and control groups. So, of course, what I want to know is, what was the control group? What was the control group? So I actually pulled the study, the full text, and Wes and I read it, and we read it, and we reread it, and we read it again. And what we looked for was any indication of what the control group was. Did the control group have loupes? Did the control group have no loupes, no magnification at all? Did they have 2 5s, 4 5s, 6 O's? Did they wear the loupes for the beginning of the procedure and then take them off? Did they put them on? There is zero information in that study at all about the control group. To be honest with you, Wes, and this is me just guessing because I don't know. My guess is that study was unaided vision, no magnification.
I think you're right, John.
Versus a scope, because to me, they would have put in there if there were,
I mean, the 6 whole, O's or 4 5s.
Yeah, because the whole, like the title of the study is the impact of operating microscope on the outcome of endodontic treatment performed by postgrad students.
It doesn't say a comparison study, does it, John?
No, it doesn't. It just says, what does the scope do for you? I think that they were just looking...
But this is what the AAE is hanging on.
Yeah, they're saying...
What is control?
Right. So my guess is, if we called the people who did this study and we said, what was the control group? They would say, oh, people that had nothing. People that had nothing. Well, John, said you can only find 18% of MB2s with unaided vision. So no freaking wonder that they would have a higher success rate of a microscope versus unaided vision. So this study, not only is it not a great study, in my opinion, because who's not using loupes these days, people? Come on. That's not even a fair study. But in my opinion, this is where we get on our soapbox a little. Wes and I kind of feel like the AAE is trying here. They're doing some marketing. They're trying to say, well, general dentists, if you don't have a scope, your outcomes are going to be worse. And they're citing a study that doesn't even... They just went through saying the Cochrane... Yeah, they just invoked the name Cochrane Review, saying, hey, the Cochrane Review's found this. So it's making it sound like they're all about the high-level research.
Exactly.
And then they go and they cite this trash. I'm sorry, not that the whole study was trash, but
no,
it doesn't even define the control group.
It's just that they did define the control group, which we're saying...
I mean, this would not be accepted by Cochrane either. This study would be thrown out immediately. They would say, we don't know what the control group is. We cannot include this. And then I guarantee you the next Cochrane review will not include that study either, because they'll say, wasn't a good study. Who was the control group? Now, maybe the control group had loupes.
Well, to be honest with you, John...
If that's the case, it was only a 4% difference in the outcome at 18 months. So I'm still saying that's not a huge difference.
Well, that study was done in September of 2015, and the last Cochrane review that AAE pulled from was 2015.
Sure.
So that means that they probably filtered that out.
They may have, or sometimes those, they get published like a year after.
Maybe published a year after.
Yeah, you never know. But I just think...
But still, the thing is, though, here, John, is that the success rate is not that much different, even if they were.
Right.
But I don't see it. So we compare study with study here.
Yeah.
And we go back to what we originally said. Okay, let's go back to what we originally said. CBCT, 54% of the time you could identify MB2. Scope, 54% of the time you could identify MB2. No scope, 50% of the time. Ultrasonic, a little increase, but no significant. Then, what about loupes compared to scopes? Pretty much the same, within 2%. 57% for microscopes, 55% for dental loupes, and then 18.2 for none.
Right, and for no magnification.
What about your results? Are you going to be Are you going to cleanse the canals better? Are you going to have a better treatment outcome? And really, we don't think that.
There's no evidence.
There's no evidence.
We're not going to say that you can't have a better outcome, because that's one thing I guess we got to be careful about here is we don't want so there's some people listening to this right now going, well, I guarantee you I'm getting better outcomes. We're not saying you're wrong. We're not saying you're wrong, okay? All we're saying is that the researchers doing the studies at a high level who are going through peer review, publishing, that's hard stuff, guys. I mean, that's hard to do, guys.
Yeah, and 312 maxillary molars were used.
Yeah.
In this study we cited here originally.
Yeah, and we know that these people are good clinicians because they're publishing their stuff. They're not afraid to be critiqued, and they're not finding a difference. Now, that doesn't mean that over time we won't see a difference start to be borne out over time. It may turn out that there's a significant difference over time. It's just all we're saying is we don't want to like say that you guys using scopes are like you're wrong. That's not what we're saying. We're just saying that like there's no literature to support that, at least that there's a big difference between loupes and scopes with your outcomes or with your vision.
The interesting thing about this study, John, is they selected for necrotic chronic periapical lesions. That was their inclusion criteria. Okay, now...
Which is the most important one to be able to see everything.
Most important one to be able to see everything.
Right, that's a good point.
And so you got to be careful when you read, when people start pulling out of things to kind of support their decision, it's hard through. But that's why you listen to us, all right? Yeah. Because we're going to cut through the muck and find out these little nitty-gritty details that might make a difference in your decision.
Now let's rescue
scopes.
Before we start to make you guys you guys hate scopes because you don't have them. Everybody's going to say dental guys don't have scopes. They hate scopes because they don't have scopes. Well,
that's not
Wes,
true.
Let's go through the things that we know scopes make a huge difference on in endo, because there are several things that we know you cannot do without a scope.
Listen, if you've got a broken file, just go ahead and send it to your specialist if you don't have a scope.
Yep.
Unless you can just reach in there and just pull it out, just go ahead and send it to your specialist. Okay? If you've got a retreat to do, I mean, if you don't have a CBCT of that retreat, okay, and a scope, you don't need to be doing the retreat.
Yeah, because there's evidence to support that.
Right.
And there's evidence to support surgical endodontic therapy.
Surgical, like we could talk about, what are we talking about, John?
Apicos
here?
Yeah, apicos.
Because sometimes you got to do it.
Yep.
Like, we like implants, but sometimes an apico might be the necessary measure to save this tooth for particular whatever reason.
Yep.
But you need to be using a scope. So what's this telling you about your referrals, John?
Yeah,
okay, so if you are a general dentist listening to this show or whatever, and you're not a specialist in endodontics, if you are a specialist, I would hope that any specialist that is listening to this show or a doctor that's referring to a specialist, that specialist has a scope, because most of the time they're treating hard cases anyway.
Yep.
And number two, that person has all-time access to a CBCT.
For sure.
Because we need that data that we get from these two things, the scope and the CBCT combined, will help us in these compromised cases. And specialists need to have these things because these are special cases.
And let me just bring it home on this just before, because this is such an interesting topic, because there's a lot of controversy, but let me just bring home one more point here. If you are asking the question, why is the CBCT the first thing we would advocate? One of the things that I think people are getting wrong maybe is they're thinking, well, with the scope, I can treat these hard cases. We're not disagreeing with that. We're not saying that with the scope, you're not going to get better ability to see certain things. What we're saying is that the CBCT allows me as a general dentist to know the cases that I need to send to somebody with the scope and the cases that I don't have to send to somebody with the scope. If I can identify the same number of MB2s with a CBCT,
and I make my life easier,
right? Why would I buy a scope if I can say, hey, I don't see an MB2 here, and I feel like the root's big enough for an MB2 on my CBCT, but I don't see it? Dude, I'm sending that to the specialist because they have a scope. I'm not going to try to get in there and dink around in a tooth that the CBCT looks odd on, because I already know that it looks odd. But if you didn't have that CBCT and you go and dinking around with your scope, I don't care how good you think you are as a general dentist. You're not as good as an endodontist on those types of cases. You should be sending that to somebody. But you didn't know that you didn't know what you didn't know because you went in without a cone beam. And we're saying, based on the AAE's recommendation, the modality of choice of imaging being a CBCT, and the fact you're identifying these same number of canals like MB2s, that you'd be maybe a little bit silly to not consider the CBCT as the first thing to look at. Not that the scope is bad. The scope is awesome. We know awesome composites can be done with it. We've seen awesome crown margins. We've seen awesome stuff from Dave Clark. We've seen awesome stuff from BioClear. We've seen awesome stuff that Alan Mead is doing with his scopes in the hygiene operatories. We've seen all kinds of awesome stuff with scopes. We think scopes are great. But let's not come in just saying, well, I have a scope, so it's better. Now, you might have thought we were just saying because we have a CBCT, it's better. We're saying, look, we got reasons for it, guys. We got reasons. We got research. We got outcomes. We got clinical data. And if you guys got that stuff, man, post it up. We'd like to see it. Like, show us the money.
Right. I don't like, just anecdotal. Like, I know that scopes are going to make you feel like when you own a scope, you're going to feel like, man, I'm just doing better endo than people that don't, because you own it. You're jaded. All right.
You can become jaded, I think.
You can become jaded a little bit. And I'm not saying that I'm against scopes, because I think it would be awesome to have one sitting in my operatory, but does it make me a better general dentist endodontist? And I'm going to say that probably significantly it will not. Maybe on a case occasionally, but to be honest with you, I'm
referring those cases.
I'm referring those cases.
Yeah, that's what we're trying to. That's the point we're trying to make.
Here's the point I want to make: is I hate it over the past 13 years where I've accessed into a tooth with just periapical diagnosis, with a periapical radiograph, without a CBCT. I hate when I go in and I have to set the patient up and I just sealed their chamber up and said, I could not complete your root canal. You've just now spent an hour of my time. I've spent an hour of your time. And what am I going to do? I'm going to send them to the specialist now. That's embarrassing. One, I mean, like, because there's this pride thing that kind of kicks in.
It's hard.
But it's the right thing. But if I could eliminate that almost all the time, and a CBCT could do that for me, and from what we know now about diagnosing and the treatment, that, hey, CBCT might help, I think it will help generalists choose which cases to refer.
Absolutely. And if you're the kind of general dentist who wants to be kind of an endodontist and treat all the cases,
hey, then get a scope.
Get a scope, man. That's awesome. Like, we're all in favor of that. We're not saying that they're bad. But anyway, we got to move on, because we
have to move on.
But it's a good conversation, and hopefully it kind of goes through a little bit about what we think.
We've established that the dental guys say that a specialist needs a scope, hands down. They also need a CBCT. But if you're going to go out right now and you're going to say, if I had to choose between a scope and a CBCT as a generalist or a specialist, if I'm starting out, I'm CBCT all the way. And John, we're saying it as the dental guys right now, is that we recommend CBCT prior to endodontic therapy, or to aid in diagnosis and choosing your cases wisely prior to starting the case. Now, let's say we've started the case, okay? Because that's what this show's all about now, is the systems that we're using. Well, step 2 is anesthesia. And I think this is the easiest thing, especially now with today's modern medicine. Now, we're not going to go into the pharmacological effects of lidocaine versus septicane and whether you should be blocking.
Yeah, we're not going down that rabbit hole.
We're not going down that rabbit right now, and I don't even want to hear it from you guys. Because
no.
We're gonna talk about that on another show.
Yeah. All
right. But listen, whatever you're doing, I'll tell you something I'm doing now is and John, I start with an anesthetic, mepivacaine or a prilocaine. Just for, something that is a little more kinder. It doesn't have epinephrine in it. But then, you know what I'm following up with now? I'm following up with Marcaine. And, the worst thing that can happen is that you're in the midst of an endodontic procedure, and you're right at the end of this. It's like 45 minutes in or an hour in, and guess what you're doing? You're taking and you're putting some sealer down in the canal. You're doing your butter technique. We'll talk about what that means. Taking and putting some sealer down in there, and you're going to put some gutta percha in there, and you're going to do some kind of warm or cold lateral condensation. We'll talk about what we do and all that. But some sealer might just get out the apex a little bit, and the patient starts hurting. That's the worst thing that can happen. So I recommend long-term anesthesia for all my endodontic cases. And because most of my patients now I'm not even giving them the option of being numb for 6 to 8 hours. I'm just saying that that's just what they're going to be. They're going to be numb. Some of that might be controversial, but in most of my cases, I'm using the Marcaine. And then what we do, and John will do this as well, is that we'll follow up with septicaine, articaine, or some type of an infiltration with articaine or some type of anesthetic that perfuses through the tissues.
And we're talking about, of course, for mandibular molars, because, when we talk about anesthesia, I mean, we all know those are the teeth that are the struggle. We're not, it's not a problem anywhere else. But
in the palatal, the maxillary arch is not a problem.
No.
Right?
And so you do your block of choice, and then do a septicane infiltration. We know that increases the efficacy. But what if that doesn't work? What do you do next, Wes?
Well, if that doesn't work, then you're doing some kind of intraosseous anesthesia, or if you've accessed into the preparation, like it's one of these situations where you might have a very hot, irreversible pulpitis.
Right.
And I recommend, okay, you're telling that patient, look, they're not feeling anything as you're going through the dentin, and immediately you hit the chamber with your 2 or 4 round burr, and they're like, doom, they felt that.
Yep.
And you stop for just a second and take a little septo and you put it right down in the canals.
Right.
Okay.
Right.
And they're going to feel a little pinch. Okay.
Yep.
And it's going to be a
Pressure.
little touch and go for a while. Okay.
Yep.
And then, but before you do that, I like a 4-point injection.
PDL. Yeah.
That's
I love
PDL.
me some PDL.
4-point injection is simply mesiobuccal, mesiolingual, distobuccal, distolingual. And that we're talking about mandibular again because that's always the hardest parts. But you got to do the same on the maxillary arch as well sometimes because that palatal root sticks way up in the palate. So you go, do those 4-point injections right into PDL. Now, I'm not talking about like some kind of halfway PDL injection. I'm taking about bending my needle at 45 or 90 degrees and burying it into the PDL or using some type of Ligajet,
right?
If you have such a thing, or just taking your 30 gauge and putting it down in the PDL and injecting as hard as you can with a dental syringe. Pressure anesthesia to shove that down in around there. If you've got a furcation you can get in, put it in the furcation.
Yep.
Now, what you'll find is that you never have to use Stabident or X-Tip ever again. I'm not saying that it's really rare. I can't remember the last time I got that stuff out.
And here's the other thing that I do that's just a little pearl is if I've got those irreversible pulpitis situations, one thing I learned from I was Dr. Richard Mounts one time is doing a good, and it's basic, but it's just if you're not sure or if you just want to be sure, do an endo ice test on the tooth. Before you access it. And it just really, started doing that on those difficult, where the patient's coming in with that lingering pain, where it's an irreversible pulpitis situation. I'm cold testing the tooth before I start anyway. And then after I do my anesthesia, I give it time and I come back and I cold test it again. And you can be pretty darn sure if it does not respond to endo ice and it's irreversible pulpitis, you got it. But it's so beautiful when it does respond, and before you go in there.
When you go in there, man.
Yeah. So you go ahead and you get the PDL in, or you do your next couple of steps. Makes a difference.
Please tell your patients that endodontic therapy is a lot better than it used to be, because it is. It's a lot better than it used to be. Don't scare them. I mean, a root canal is a bad word because it was given a bad word because anesthesia was terrible 20 years ago.
So let's talk through what you do next. So you got your anesthesia. Assume the patient's numb. Now what we need to do is we need to isolate the tooth.
Yeah, but John, CRA reports that up to 70% of people with general dentist or just people doing endo don't use rubber dam.
It's the ultimate facepalm, dude. This is the Picard facepalm.
Let's just go ahead and just chalk up some checks. Just write some checks now.
Just go ahead and get your license out and burn it. Just burn it.
But I wonder how many cases are settled yearly. We won't know this because it's all closed. See, you don't know, because whenever you get a suit for a file that goes down your throat, they just want paid.
Yep.
And so how many of these cases never go to court? Because if up to 70%, John, are not using a rubber dam, files are going down people's throats.
Guarantee it, man. Guarantee it.
Files are going down people's throats.
Yep.
What in the world are we doing, people? Put a rubber dam on. But doctor, I can't do it. I can't isolate. Then don't do endo.
Right. Then just send everything out, man. Like if you can't
seriously,
if you can't do it, if it's too hard, then send everything out because you have no business being in there. I mean, it's one of the few things that you
wasn't there some other statistics you told me in pre-production?
Well, the ADA did a study, pretty good study on this, where they did a nice, completely anonymous survey about what rubber dam use was. They did this back in, I think it was 2014, and they found that they did 729 people responded, and they said that of those, only 44% used it for all root canals. 24% used it for 50 to 99%, 17% for 1 to 50, and 15% never used it. Like, they reported
Start
themselves.
Writing checks now.
I never use it.
How many people are having to write checks for this?
It's crazy. So just, we don't even want to get into this, guys. Just don't do it. If you can't put a freaking rubber dam
John,
on.
What are you doing for rubber dam right now? I mean, I know you got good clamps. You know,
I'm just using a basic one. And I do have a special. I do have some special clamps that I use. I use the ivory. They're the ones with the little. I can't remember the number now. But it's a pediatric molar, actually.
Love it. I know
that
the
has,
one you're talking about.
That has a little what do they call the little like spikes on it? The little spiky guys. And I can't remember the name of the stupid thing right now, but it's a pediatric molar. So it's got a small side and it's got a large side. You know, like the old pediatric ones used in dental school, they've got different sizes. And it's really nice if you've got a broken tooth because you can sneak the that sharp small side down the palatal.
It's like a 13A for the
something
lower.
like that.
Is
Gosh,
it? I don't know.
It's something like that. I got to look it up, but it's a nice. I think they're called like Tiger or something like that. They're like that has like those little grippies, and it makes a huge difference. I'm just using a regular
just serrated. They're serrated.
Yes, exactly. And I'm using a regular old non-latex rubber dam. Nothing special. Just get whatever's cheap. That's for me. But you like the Handy Dam, right?
Yeah, man. Lexicon has it. It's by Den Supply. I really like it. Not a sponsor, but I mean, I've been using Handy Dam for years. And the reason why I like that is because occasionally, you know, I got to shoot a PA. You know, it's rare, but occasionally, like, I'll be like, man, something's not right with my ZX, and it's like, give me some real weird readings, and I'll go ahead and take a shot of seeing where my working length is. And, you know, it's great to be able to just kind of bend that Handy Dam back. Hey, look, and if you haven't even tried the Handy Dam, just get you a pack and try them.
Yeah.
They work really great, and the thing that I like about it, basically, it's a frameless rubber dam that has a kind of a rigid plastic frame that's still bendable.
Yeah.
Handy Dam is the way to go. I've been using it for years. It's funny though, I started out doing just a regular, I've got an endodontic frame still on, a rubber dam frame on my cassettes, but and occasionally I still pull out my rubber dam, especially whenever I'm doing multiple units, okay? So like, yes, doing 2 root canals side by side, I use a regular rubber dam for that. And I use floss a lot of times to tie, but John, there's one other thing that you and I, it's interesting because we come from the same kind of background as far as our training, is we'll both get our rubber dams on. We've got a bite block in there. And I recommend that for anybody that's doing endo, get you some bite blocks. We both like the Logi block. That's the one that's kind of has like the C shape and allows you to kind of get your suction in there. It doesn't block you. Logi block it's a clinician's choice. I know that we're kind of, you know, that's the same company John and I've talked about in the past. It's brought some good products, but Logi block. Yeah. But John, we add one little thing right there. My assistants have it on the tray. Is some type of liquid dam to seal any nooks and crannies out from, you know, any of the sodium hypochlorite or some type of irrigant, whatever you're using, so that saliva doesn't contaminate and that you don't get sodium hypochlorite down people's throats.
Yeah. I think you got to use that. Or the other product that I like that's similar to that is Ultradent makes a product called OraSeal.
OraSeal's amazing.
They've got a putty and a caulking, and basically they are self-setting. They respond. They're like a cellulose, and they respond to moisture. So you can inject, you know how Ultradent's famous for their syringes? Well, you can inject this stuff around the rubber dam, and it will set in the presence of moisture or saliva, and it will adhere to the rubber dam and the wet gingiva, and it will seal up. If you can't get, you know, isolation enough to light cure the light cured rubber dam stuff, but you got to have something like that, you know, because you're never going to get a perfect seal.
Where liquid dam really comes into play is whenever you have your really bad decay goes way below the gum line, and you know that your crown margin is going to be way below the gum line, and you're cutting into this mesial or whatever on a tooth. Hey, you could take your rubber dam's obviously not going down there.
Right.
So you can still see the tissue. You just take and paint this stuff on that tissue and run it up interproximally, and it forms this little hard shell.
Yep.
And it is so protective because you take that off, it just flicks off with an Explorer at the end of the case, and you see how pink and healthy the tissue is because it's not damaged.
Right.
And it's just
and great. It doesn't bleed all over your access.
Yeah.
Too, which is big. The other trick that I learned from an endo resident back when I was in school that I've used forever is, and it's again pretty simple, but I never caught on to it, is if you got a really deep subgingival decay removal that you're doing, like you're talking about, where you get in and you could easily, you're getting seepage in there. One trick you can do is get any kind, doesn't even matter what kind of matrix down there, anything you can kind of get, and just squirt a bunch of Fuji-9 down there and let it completely set, and then go back and redo your access through the Fuji-9, leaving that wall, like the distal or whatever,
talk about that for
in
just
place,
a second.
so that you have something that will keep the seepage out, seal well, and then when you're done, you just zip the rest of it out and put your definitive restoration in there with better isolation once your rubber dam is off.
So a lot of times in these worst case scenarios, people ask me, do I do my core buildup before or after my endodontic, access? And so the first thing I do is I assess the situation from a standpoint of decay. If I've got a big giant MOD amalgam in there, I may, and I don't have a lot of decay, but I've just got a hot tooth that I've got to go in, or a necrotic tooth, I may just remove enough of the amalgam to get it out of the way of my ZX, okay, so that no metal comes in interference, and leave my interproximals, because I know I'm going to come back, and that acts as a seal, so that's not a decayed situation. And then I'll come back and remove and do my, my core buildup later. But in a situation where John and I are talking about where you have a massive area of decay, sometimes it's best to go ahead, remove your decay, get into your chambers, identify your canals, okay, and then go ahead and put you a little cotton pellet down in there, or something you can see, maybe a little piece of your endo sponge, just kind of blocking out your canals. Go ahead and throw in some Fuji-9 or core buildup material. Put a big giant. And this is before you put your rubber dam on, even sometimes, okay? And because a lot of times we're accessing without our rubber dams on, we'll access so we can see,
right? And
then we'll go ahead and put a rubber dam on, and we've got to have and put a buildup on, and guess what that does for you? That allows your rubber dam forceps to be able to, or not forceps, your rubber dam clamps, retainer to be able to stay on the tooth, because now you can actually use the buildup as retention.
Exactly.
And you're not having to grip down on the tissue, which is never fun when the patient wakes up, you know? Yep. So isolation is key. I think the next thing for us, John, is access.
Yeah.
And this is one of these things, where it's kind of it's changed. It used to be like a small, like I can remember like the first time seeing some of these accesses like 10 years ago for my endodontist when I referred a lot of my cases. I'm like, how did he do this? He was working through a needle hole.
Right.
And it's like so small, so conservative. Like, how is he unroofing the chamber? And then it was like, we go to our courses and then we hear like conflicting like science, and like Ruddle and Buchanan were telling us like, dude, open this thing up, unroof the chamber. I want to be able to take my whole hand and put down in the canal. But John, it's really come back a little bit, and it's conservative now, John.
Yeah. It's been interesting to see that. When I first started going to CE after in school, you're always so worried about, doing anything to a tooth. And so you tend to always under-prepare your access, because you're worried. And then you get out, and I remember seeing Cliff Ruddle, and he was saying at that time, hey, man, if you can't see the canals, like, what difference does it make if you conserve tooth? At the time, he was saying, if you can't actually do good endo. He's like, you can conserve all this tooth, but if your endo fails because you couldn't get into the canals, then you lost the game. But then a few years later, it was kind of seeing it go back the other way, especially with Buchanan kind of saying, guys, we've been sort of blowing these teeth out, and we're seeing that maybe we cause more fractures, maybe more failures long-term, because we're making these beautiful accesses that were huge and we get great straight line access, but do we really need it? Because the files were getting smaller. We went from those big GT files down to these variable taper files, which we'll talk about another show. And all of a sudden the accesses could get smaller, and we realized that we really didn't need to have those if we had the right orifice shapers, blah, blah, blah. And so now but it kind of follows with your practice, doesn't it, Wes? I mean, you start off conservative, then you get bigger because you realize you can't see anything. And then as you get better at it, you realize you don't have to make it quite as big, but you get to what you kind of figure out that there's a middle ground there where you're conserving tooth, but you're still getting enough access that you're getting all the pulp chamber open enough that you can get it completely debrided.
I think the top thing that I've done and over the years is when I first was learning good endodontic therapy, just doing some accesses on some extracted teeth.
Oh, yeah.
And, just take a handful of like 20 teeth and just access them.
Just learn something.
Just learn something, man. And you just sit there and you access and you access and you access and you start to see a repeated pattern. I'll tell you something else that has really changed how I access teeth is my CBCT machine. Because now I can go from this coronal slice and actually look at where the canals start, where the pulp chambers begins and where it ends, and kind of measure it. You can measure it within a 0.5 millimeter accuracy sometimes if the patient's still, and really get a good idea of what working length is, where you should be. Like I tell you, the toughest cases when you're going through a crown and you're preserving the crown. It's like, man, I like to measure now from the top of my crown to where to the bottom of the chamber, and I can actually measure that on my burr. Yep. And so if you have a CBCT, start looking at that, looking at your access. But John and I will tell you that one of the greatest things that we did is like, well, how do we know what to buy? Yeah. Like to access this stuff. And so both of us, again, it's like a brother from a different mother here.
I know. We didn't know each other at all at this point. We were going to all the same courses.
Yeah, it's so interesting. But both of us, we're going to recommend that if you're new to endodontics or you're just getting in or you're feeling like, hey, look, I don't really know what to buy. Okay, it's hard for us to tell you what we really, really would recommend for you then, okay? But if we had to start somewhere, we're going to recommend there's a product by Kerr. It actually was designed by Stephen Buchanan. Yep. It's called LA Axis Endodontic Kit, okay?
Yeah, and it's AXXESS with access. Right. So if you're searching for it's instead of ACC, it's AXX.
And when you look at this, you think, man, that's a lot of burrs, Wes and John. To be honest with you, now we've narrowed our kits way down to 4 or 5 select burrs that we use for access. But this is a great starting point. I mean, it's got everything from, a great white. It's got diamond round burrs. It's got pear-shaped burrs, and you think, man, that's a lot of burrs. But let me just tell you, one of these
side cutting and
it's got all kinds of different things in there that will really help you determine what you like.
Yep.
Because you really don't need much. You really don't need much, but you need to start somewhere. And if you're new to endo, now if you're out there and you're saying I'm a seasoned expert, what are you using, Wes and John? I tell you what, I use a long shank friction grip 2 and 4 round burr for my primary access. Now, if I'm going through some porcelain, I like to use a round diamond 2 or 4 round, and then when I go to the metal, I put on some type of some kind of metal cutting burr. It's like a carbide cutter or something like that. Most likely it's a great white, and I'm going around and I'm refining the metal part of that thing. That's the hardest part. Once you get past that, then I go back to my 2 or 4. And once I go to my 2 or 4, I'm physically measuring from the marginal ridges where my canals would be based on my CBCT today. That's what I'm doing. And that actually kind of gives me a great, and I'll tell you what, it's helped my access having CBCT. But before that, if you memorize in the endodontic textbooks, it shows you the picture of the possible, canal morphology and what that could predict as far as like what the chamber should look like. And so 2 or 4, and then we're going in there, we're finding our canals, and then I'm using some type of maybe an orifice shaper, something that just going to kind of clean that. Most of the time I'm taking 1/4 round long shanks, and I'm going down and just kind of cleaning off little spicules and things like that because I don't use an ultrasonic, and I'm trying to find my canals. And that's kind of like my access regimen there, John. I've got a few, select burrs on there, some diamond flames and things like that just for opening things up a little bit. What about you?
Yeah, my initial access is the same. I use a long shaped round, either diamond or carbide, depending on what I'm going through, and then I transition to a slow speed round, same kind of thing, 2 or a 4, usually a 4, until I get to the chamber, and then I a lot of times I'm using a diamond, a nice flat end. I have it's actually the same burr I use for crown preps. It's the KR, flat end with a round internal line angle, and I like it because it really is not very aggressive cutting on the end, and it just basically allows me to develop a nice taper from I basically, once I find the canal orifice, I'm going to put the end of that burr, the diamond, right into the canal orifice. Just kind of
right into that canal.
Yep. And then I'm just going to kind of lean it just a little bit, just to try to create some kind of access, not necessarily straight, quote unquote, straight line access, but a modified idea of straight line access, just so that I have a nice smooth outline, right? Nice smooth outline where I'm not going to bind up with any of my files. And so I'm finding that I'm probably 50% round burr and 50% diamond for just refining the shape of the pulp chamber.
So John, what you're saying is like it's maybe 4 or 5 burrs that you've got on your kit.
I mean, it's basically, for me, it's 2 burrs. It's a round burr and it's a diamond for me. And then if I need to go through metal, like you say, or porcelain, I've got either a round diamond or a metal cutter. That's it. I got 4 burrs that I use. I never pull anything else out.
Here's the thing is like, we're recommending this LA Axis kit because it helped us determine what we want. Don't just go buying what we have, because for you might not come to the same conclusions. And there are some burrs on here that do some of the same things, but actually they're a little safer.
Yeah.
They're a little safer. And when you get good at endo and you start getting like, okay, I can do this with another burr, and maybe this will work and it's fine and I don't have to reorder that. That's fine. But this is a great starting point for you guys are out there. John, I feel like that we've turned this whole thing, endodontics, root canal therapy, into something that really is going to span multiple shows. And I'm excited about really what's going to happen next time. Again, you guys are going to have to listen to another show about root canals. And next time, it's going to be discussing irrigation. We're going to be discussing shaping the canals. We're going to be discussing, like, should you,
working
agitate,
length,
working length, root ZX, like what is this research currently showing? How should we be taking working length shots, cone shots? What type of obturation?
And we may actually finally get to discussing files. And, that's like a whole show.
Hey, John, can you do root canals without an auto-reversing handpiece?
This is going to be interesting. It's just a little taste.
John, bring us home.
Well, you have spent some more time with us. We appreciate all the time you spend listening to us here in the Dental Guys. We love being able to come into your car or your house or your run or whatever you're doing right now as you're listening to us, sitting in your office eating your lunch, learning hopefully a little bit about some of these things as we're learning along with you. It's always a pleasure. If you like what we're doing, please engage with us. Let us know how we're doing. We'd love for you to leave us a review on iTunes. That helps other people to find us and the slew of other dental podcasts that are out there. We'd also love it if you get on Twitter or Facebook and hit us up. Give us with any questions you have or any ideas that you have for shows. If you've got research to completely debunk everything we've just said, that's awesome. Like, we love it. So bring it on. We love to have those discussions. We want to make sure that we're doing things the right way. And so we welcome all of your feedback, whether it be constructive or critical. We love it. It's good stuff. We would love for you to just engage with us on social media so that you can spread the word about our show. Tell people that you think might be interested in our show about us. Tell them that you like what we're doing. Tell them that you like the fact we're trying to keep it clinical and research-based and not just try to sell you something. And that's the way that we've kind of always said from the beginning that we're going to be. That's why you keep coming back, and that's why we're going to continue to do what we do. And for Wes, I'm John, and we are the Dental Guys.